My name is D.W. Park from Assam Medical Center. I'm going to start this session. This session is the first session this year, Complex PCI 2020 virtual meeting. This session title is Complex PCI e-training session 1, left main and bifurcation PCI. I'm going to introduce, we invited the worldwide famous interventional cardiologist as moderator and panel as a lecturer. I'm going to introduce co-moderator, Dr. Alan Yeung from Stanford University from the United States. And I'm going to introduce the panelist, Jung-Min from Assam Medical Center and the Stanford University, and Dr. Kefei Do from Fai Hospital in China, Dr. Sunao Nakamura from Japan, Dr. Teguh Santoso from Indonesia, and Dr. Kenji Wagatsuma from Japan. Okay, Alan Yeung, could you introduce the speaker?
Yes, thank you so much. Don't work. So I have the pleasure now to introduce our first speaker, Dr. Seung-Jung Park. He's going to talk about integrated image and physiology for left main bifurcation PCI. When and how? SJ?
Okay, my talk regarding the integrated use imaging and physiology for left main bifurcation PCI, when and how. So at first, why FFR? So we have already changed a lot in the real practice for the, especially for the main disease, intermediate main disease with the downstream. There are still almost 30% of mismatches, so mainly a little bit different with the non-main epicardial arteries. Look at this is typical cases. Insignificant stenosis for the main, however, FFR 0.72, strong positive. If you look at the obvious findings, diffuse disease from the ostium to the proximal LAD concern. In case of intermediate main disease, relatively higher frequency of reverse mismatches. The reason why actually main artery supply the relatively large, myocardiums. FFR guided means, that ischemia guided. How do I implement FFR for main PCI? In case of ostial sharp main disease, FFR is definitely helpful, the positive negative concern. However, in case of bifurcation main disease, and may have some problem to measure the FFR. So look at this. If the presence of large circumflex side branches, does it really matter in terms of practice concerns to measure the physiological FFR? Right, look at that. The downstream disease in the case of the main, we actually, excuse me, we can apply the tandem lesion concept. Look at this, and so this is in vivo validation. Proximal LAD, a certain degree of obstruction, whether we can measure influence of large side branches and measure the FFR in the lamina. Look at this. This is schematic. If there are some, gradual stenosis of proximal LAD, look at this, distal part of FFR decrease mid portion in terms of main, measure the FFR a little bit increase. Actually, the FFR main measure the FFR actually would be overestimated, and the degree of difference, also the degree of overestimation is not too big, 1.01, 0.02, and in the presence of large size branches, measure the FFR would be overestimated. However, the difference true and the measure difference is very small. Therefore, the FFR still work in real practice in terms of almost same concept with the tandem lesions. However, another realistic issues, main stenosis are very isolated. Almost 90% of plaque extended from the main LAD in main bifurcation disease. Almost 90% the disease extended to the LAD and circumflex. And so I would say main bifurcation disease would be one of a single unit of disease. And so we can measure the FFR even in the distal downstream disease here. FFR walk to positive and negative concern. So it does not really matter even in the presence of a large side branch concern in the practical issues. What does it? IBUS measurement for the IBUS, supported main PCI concern, right? Real practice, IBUS MLA in overlap main disease really can't predict the functional significance of stenosis. This is only data 2004, just this data. Minimal lumen area 6 millimeter squares matched with a positive FFR, less than 0.75. In 2014, we presented our data, just 6.0 cutoff value may be relatively too big to estimate the functional significance. And so we included almost 112 patients, 4.5 IBUS MLA cutoff to matched with this 0.7, 0.8 FFR. Actually, the cutoff value is 4.5. And if you look at the positive predictability, our value is 83% accuracy, 80%. So we can clearly use IBUS MLA 4.5 millimeter scale. Less than that, maybe the reason would be functionally significant. So how do I implement Osteal chapter lesion 4.5, less than 4.5 millimeters IBUS MLA directly related to the positive FFR, and downstream disease more than 6 millimeter scale is absolutely almost 100 matches with negative FFR. Between the two, between the 4.5 and 6 millimeter scale by IBUS MLA, still we have to consider measure the FFR. So, all right, practical concern. How to do the main bifurcation PCI. One stent crossover, whatever bifurcation disease, just 2 stent crossover and 2 stent and multiple 3 stent for the side branch concern. 1 stent in case of a normal or diminutive circumflex, small circumflex less than 2.5, and we can just crossovers, and 2 stent diffuse disease in larger circumflex more than 2.5 millimeters, we have to consider 2 stent from the beginning. So when we have to consider 1 stent crossovers, when we have to consider 2 stent, you get according to the circumflex disease status by IBUS readers, the first one, excuse me, true bifurcation disease by angiographic findings. However, IBUS findings clearly show the circumflex ostium is absolutely free of disease, normal. And so we did just a single stent crossover, so for the main disease. The second one was truly bifurcation angiographic disease. However, IBUS findings is severe disease in circumflex ostium, pretty much plaque on the circumflex ostium. And so we did 2 stent crush technique for that. Angiographically is almost the same, stent crossover 2 stent technique. Right, so if there are circumflex disease, means true bifurcation and main disease, upfront 2 stent structures are recommended for main bifurcation. Large circumflex disease is worse of treatment. We can avoid the risk of side branch closure. Clinical outcomes of the 2 stent actually very equivalent, very good compared to the single stent crossover. Right, this is typical examples. 1 stent crossovers for the normal circumflex, 72 unstable angina, true bifurcation. By angiographically we cannot discriminate is it truly bifurcation or not. But I was finding clear circumflex ostium is rest, is very minimal plaque for the ostium. This is schematic presentation of the presence of plaque. Circumflex ostium is minimal plaque, and so we did just a stent crossover and high pressure inflation, and then you can get the very good angiographic result here. Post-stent IBUS circumflex ostium is well preserved. Still, MLA is almost 5 millimeter scale. Look at this. There are many cases. Circumflex jailing after there's stent crossover from the LAD to the main here. Look at this. Very tight stenosis, 80%. Already loosened area by a stent strut. Some calcific lesions. We have no idea, but really functionally significant or not. However, FFR is all cases absolutely negative. Many cases of a mismatch is tight stenosis and negative FFR if there is circumflex after main stent crossover. So in those cases, compromised circumflex ostium, do we have to consider final kissing balloon inflation? So this is small data. However, look at this. After the stent crossover normal-looking circumflex, functionally significant circumflex swelling is only 7%, very small percent of compromised circumflex has a functionally significant stenosis. If you look at the clinical outcomes in terms of death and MI, that's why MI is a hard endpoint concern at 2 years follow-up. Actually, just the T4 and kissing balloon inflation, actually no difference at all. No final kiss. That means the circumflex T4 is safe and good. So bifurcations, one stent crossover for the normal circumflex. Final kiss not always necessary in almost more than 90%. The two stent for the true bifurcation. So whatever you choose, TK crosses, mini crosses, T stent, or Y stent. Look at this typical examples. True bifurcation disease. If you look at or circumflex ostium is truly disease status. And so we did in this case is sequential, classic mini crushing technique. So two stent. Circumflex ostium, LAD, and the final kissing inflation. This is classic mini crushing technique. Is good angiographic result. The final IBIS MLA, circumflex 5, LAD almost 9 millimeters is quite enough. Minimal, stent areas. This is our data. Effective stent area after two stent. The minimal lumen area is more than 5, 6, 7, 8 in each circumflex LAD polygonal confluent main area is the reasonable less than 5% and TLR less than 2%. Meaning whatever you choose the two stent technique, important prognostic factor is effective stent area of 5, 6, 7, 8 can make a very good reasonable rate at 2 years. It is just the angiographic two stent technique, a little bit higher reasonable rate so far. So true bifurcation, final case is really necessary in almost all cases. So multiple stent for true bifurcation disease PCI. So in the era of integrated use of FFR and IBIS for the main bifurcation PCI, if you look at some data, maybe Shaoliang Chen will show us clinical outcomes of one stent or two stents are almost equivalent. So I would like to show final complex upfront 3 stent for the main disease. This is truly trifurcation, including the Lamus branches, circumflex. There are truly trifurcation disease, and so we deploy the 3 different wire and 2 branches, circumflex artery, Lamus branches as a stent first, and then we did balloon crush first, from the LAD to the main. This is the final 2 stent, Lamus and circumflex and balloon crush, and then finally we did main LAD stenting, 3.538 long stent, high pressure inflation, and we can make a very good angiographic result. And finally, sequential high pressure inflation in each vessel is stented arteries, Lamus and circumflex, and LAD, finally triple kissing balloon inflation and simultaneous in the 3 different stent area. This is final angiograph result is truly perfect result in the spider view and another area view here. So out of summary, practical guideline in terms of by IBIS findings, both LAD circumflex you should do that, and normal circumflex ostium single stent. In practical concern, even in the bifurcation disease by angiographic findings, almost 75% of cases we did single stent crossover, and still there are significant jailed side branch concerns. We have to consider FFR, how to treat, and final kissing, and optimal optional T-stent technique. Truly bifurcation disease, any 2 stents, including the DK crusher, good, 25%, and how to optimize. Finally, IBIS stent cross-sectional area of 5, 6, 7, 8 millimeter scales can make a very good long-term clinical outcome. So this is conclusion. Distal lemon bifurcation PCI, outcomes of 1 or 2 stent are almost equivalent. How to treat the combined multi-vessel disease, that's the remaining issue for the main bifurcation PCI. Thank you. for your attention.
Thank you very much, SJ. We will come back to it for more discussion. Our second speaker is Bon-Kwon Koo from Seoul National University. He's going to talk about Bifurcation Tech Review 2020. This is the provisional strategy with the FFR concept. So, Bon-Kwon.
Thank you, Dr. Yeung, for the kind introduction. So I'd like to talk about the provisional strategy with FFR concept. The definition of provisional actually includes some uncertainty. So the question is why we should start with the technique with having some uncertainty and not starting with the more definite upstream two-stenting strategy. So for that aspect, I would like to approach from these 5 aspects, and let me start with the standardized approach. In general, when you think about the standardized approach, we look at the guideline. And here there's a decay crush, but still a provisional stent is still class 1A level of evidence A recommendation for general bifurcation lesions. So this is a standardized approach. And here you're looking at the strategy changes in 10 years in Korea. So this is simple crossover and 1 stent with side branch ballooning and 2 stenting strategy. So the simple strategy has become more and more standardized with the decreasing number of 2 stent. And at the year of 2014 and 15, it's around 17%. All these others are provisional. I would say that these are the standardized approach. We recently have a very nice paper from Dr. Shaoliang Chen's group, which compared the 2-stent and provisional strategy in definition 2 trial. And it is surprising to see that in this study, main vessel lesion length around 40 millimeter, side branch lesion length around 20 millimeter. And when we reviewed our data around 5,500 patients, these more than 40 and more than 20 is only around 1%. So that this is a beautiful study to show the benefit of 2 stenting. However, I would say that considering all this distribution of lesion severity, provisional is still a standardized approach. And then think about the procedure safety and simplicity and complication rate. So provisional approach is simple. Actually, it's one key element is main branch stenting and all the other is optional. So provisional approach makes a bifurcation lesion like non-bifurcation lesion, and you can recognize how simple it is when you compare the other 2 stenting techniques. So here is a miniaturized process of 2 stenting technique. You should do all these procedures one by one, following the image guidance and angio guidance and using several different devices, and you can have a final. But the thing is that all these are optional, but all these processes are mandatory. So provisional is simple, no doubt. And the other thing is that the optimization technique. So here is COBI's 2-3 outcome data. As time goes by in 2 stenting strategy, we are having more path and similar trends of the kissing. But in this 2 stenting technique, whether you use image, whether you use a final kissing balloon, whether you use a path, this is a prognostic discriminator. So you should do all these things in the right direction. But when you see a 1 stent strategy in 10 years, KBT frequency decrease and path increase, but when you see the outcome determinant, there can be some influence, but these were not a significant discriminator. So that you can still choose these procedures, but even with the much simpler procedure, even without this optimization technique, you can have a similar outcome than those without. Some may argue about the safety. So this moderate size branch has gone after crossover simple stenting. And this is the reason why some people hate the provisional approach, because this can be dangerous in big circumflex artery. However, if you see the side branch occlusion rate during the procedure from 2003 to 2015, it decreases a lot. And during the procedure, it happens only 3.3%. And this, in general, can be fixed by the strategy. And if you review the definition 2 trial data again, for these very, very complicated lesion subset, the excellent Chinese doctors and international doctors during the procedure, side branch slope flow happens less than 1%. So I would say all these results support the safety of provisional strategy. Then let's think about the success rate. So this is before stenting, and this is after stenting and kissing balloon inflation. And according to the angiographic criteria, I should say this is failure. So we should do something. But if you see the physiologic significance of this lesion before and after, I'll be very happy with this results, and I would say success. So there can be a different definition for success and failure, whether you choose anatomical stenosis severity versus functional status. There has been so much data support that the anatomy cannot tell you the functional significance. So here are 5 jailed circumflex branches after left main to LAD crossover stenting. If you measure FFR, you will see some are bad and some are good. And people may criticize that as anatomically all are significant, I don't care that much about physiology, and I don't think physiology makes an outcome difference. But here, when you see a data, 5-year outcome of jailed circumflex according to FFR, during 5 years, low FFR has a far worse outcome, almost 3 times higher risk of events than high FFR, and high FFR 5-year event rate is only 10%. So it's safe and FFR matters. So finally, I'd like to talk about the long-term outcomes. So here is a long-term follow-up angio, and you see that this is angio. 14 years ago, left main to LAD cipher, and 14 years later, there is a jailing of the circumflex ostium and diagonal ostium, and some may criticize that when they encounter this kind of images, and they argue that this is the reason why I want to do 2 stenting upstream to avoid this kind of a complication. But I can also argue to show this kind of images. This is a mini crush to a 2nd generation DES, which was done by the other hospital. But 13 months later, total occlusion of the circumflex artery. And I can say that this one is far better than this one. But as a scientist, I don't want to say that showing these 2 cases, which one is better and which one is not, but we need to follow the data. So I showed you earlier, this is a 10-year trend of Korean bifurcation treatment. So then you may wonder about the outcomes, so that while we are using more and more provisional strategy, actually the outcomes gets better. It's good that the 2 stenting strategy has become far, far better than 10 years ago, but still the outcome is better with the upstream provisional strategy. And this is why I argue that the provisional strategy is still a standardized approach. And recently we have several different meta-analysis or network meta-analysis, but in this 2 years ago data meta-analysis of randomized trials with the long-term follow-up, there was a long-term mortality difference, not TLR, not TVR, but mortality difference, which supports that using the provisional strategy can reduce the long-term mortality in the long-term follow-up. So here's another story, so that it looks bad, but when I measure IFR, FFR in this diagonal branch and circumflex branch, all were good. So even if I show this kind of a good physiology, but some may argue that when we do an OCT and very nice fine imaging analysis, this is 6 months later, obstructing struts are fine, but 18 months, something happens. So this is the reason why some doctors does not even believe in FFR and do something, especially OCT guided strut selection and very nice additional procedure. But there's also another story. So this is an OCT, which I borrowed from Dr. Shimoka. And this is a post-PCI OCT, 6 months later, 18 months later. You see that something happens here and some bad things happen here. So that some may argue that this is a bad thing. So I don't like this. I would like to open this strut. But if you see the angioscopic finding, you can find that this is a very nice, healthy neointima that cover the strut, so that this cover does not increase the risk of stent thrombosis, and it may not be a big matter in terms of flow, and also you can do easily the further procedure because of very thin, healthy strut coverage. And that's the reason why in 5-year follow-up of COVID-3 data, more than 2,000 patients, when we compared the simple crossover and side branch opening, there was no difference in target lesion failure in 5 years outcome. And also there's no difference in cardiac death. And these results were same even after the adjustment of all baseline characteristics. And also you recently see the 4-year outcomes of Excel trial, when the operators divided the patients with the final kissing balloon inflation and no final kissing inflation. There were no difference in unadjusted and adjusted outcome regardless, according to use of final kissing balloon inflation for death MI stroke or the death MI stroke ischemia-driven revascularization. So here in 2020, I would say that provisional strategy with FFR concept should be the primary approach, because that this is a standardized approach. Procedure is simple and safe, and this is associated with the low rate of complication, high rate of success, and favorable long-term outcomes. Thank you very much for your kind attention.
Thank you very much, Bon-Kwon. So we're going to move on to our next speaker, and then we'll come back for discussion. So Shaoliang Chen from Nanjing First Hospital is going to talk about Bifurcation Tech Review 2020, the Upfront two-stent strategy.
Okay, thank you. Once again, thank you, SG, for inviting me to present Upfront two-stent strategy. I think it's a boring topic we have discussed for many years, but it's still a hot topic during our daily practice in our case levels. So I have nothing to discuss. So basically, I'd like to present why do we need two-step approach. In general, so far there are only 4 multi-center randomized study compared to provisional with different two-step technique. So of them, 2 randomized study came from Europe, Cactus and BBC One to study compared to provisional with either classic quash or different kinds of two-step technique. So finally, at 1 year follow-up, there was no significant difference between, in terms of the MACE at 1 year between 2 groups. So it looks like provisional stenting is much better than two-stent technique because of less layers of stent struts. But the remaining question for provisional stenting technique, so is the comparison of provisional with one stent technique compared with the provisional with the two-stent technique. On the other hand, from our DK-Quachi-2 and DK-Quachi-5 study, even finally we got still negative results, non-significant difference in terms of the MACE at 1 year between provisional and DK-Quachi stenting technique in our DK-Quachi-2, but we found a very low rate of clinical-driven TR in the DK-Quachi group. Finally, in our DK-Quachi-5 study, the primary endpoint was one year TRF, so we got very significant reduction of primary endpoint at 1 year in the DK-Quachi group. So in general, from these 2 DK-Quachi studies, maybe DK-Quachi looks like much better than provisional stenting technique for relative complex bifurcal lesion. But also we provided the superiority of DK-Quachi stenting or Q-Lot stenting technique for distal left main, Medina 111 and 011 bifurcal lesion from our DK-Quachi-3 study. So based on the previous data, so maybe there is a very strong correlation between lesion complexity and clinical outcome. So firstly, I'd like to say CTO lesion, left main, and acute myocardial infarction were not included in either Cactus, BBC One, or Nordic study, but they were included in our DK-Quachi-2 and DK-Quachi-5 study. Furthermore, side branch lesion length was around 8 mm from Cactus study, but not reported in the BBC One trial. For Nordic study, the side branch lesion length was around 11 mm in two-stent group, compared to only 3 mm in the provisional group. To be as a randomized study, I think this is not good for Nordic study because very short side branch lesion length in the provisional group. Also, Nordic study group provide the baseline diameter stenosis at the side branch was only around 40%. So it means very less pliable burden as the osteotomy of side branch. In our DK Quachi 2, side branch lesion length was around 12 mm. And it was 16 mm in our DK Quachi 5 study. So again, the result indicated the strong correlation of lesion complexity and clinical events. But another point is that provisional staining technique may not work equally for simple or complex bifurcal lesion. So in the 2018 ESC guidelines stated that two-step approach may be preferable for complex coronary bifurcal lesion if side branch diameter more than 2.75 mm, or side branch lesion length longer than 5 mm, or opposite field. It will be difficult to access the side branch of the main vessel staining. But I think we have to question about this criteria to differentiate complex bifurcal lesion. As a result, the next issue is how to define complex bifurcal lesions. In 2015, our group combined the 3 databases in China. So we built the definition criteria from 1,550 patients with all kinds of bifurcal lesion. This new criteria will be validated in another group with 3,660 patients, also with different kinds of bifurcal lesion. Finally, for definition criteria, the general requirements are Medina 111 or 011, 2 kind of bifurcal lesion. And the side branch diameter minimum 2.5 mm. So if any lesion either localized at the distal left main or non-left main, the same requirement was the side branch lesion length minimum 10 mm. But side branch diameter stenosis is minimum 70% for distal left main bifurcal lesion and 90% for non-left main bifurcal lesion. Also provide 6 minor criteria after rigorous analysis. So if a lesion have 1 major criteria plus any 2 minors, so it could be defined as a complex bifurcal lesion. I think this is first criteria to differentiate simple from complex bifurcal lesion, but it needed to be tested in randomized clinical trial. So according to the RCQ, we provided the sensitivity and the specificity for only major criteria or the combination of major plus minor criteria. So from the table, you can see, even we only rely on the major criteria, so the sensitivity and the specificity were also higher than 70%. After the combination with the minor criteria, any 2 minor criteria, so which could be increased up to 80%. This criteria further tested in subgroup analysis from our DK Quachi 5 study. After we got a very positive, very significant difference between DK and the provisional group for distal left main, Medina 111, and 011 bifurcal lesion. So according to the definition criteria for patients in the complex group, pretty high 1-year TIF in the provisional group. It was 18.2% compared to only 7% in the DK group. However, in the simple bifurcal lesion group, even the absolute value of 1-year TIF was 8% in the provisional group, but it was non-significant different to almost 2% in the DK Quachi group. I think this is the second sign to indicate the efficacy of this new definition criteria for differentiation of simple from complex bifurcal lesion. I think this is the final reason why we need to design a definition 2 trial. We have to test the efficacy of this definition criteria for real complex bifurcal lesion. Also, based on this new criteria, we have to identify if there is a presence of real treatment effect between 1-stent and systematic 2-stent technique. So the primary endpoint was 1-year TLF. All patients are classified by complex bifurcation lesion according to the definition criteria. In the two-stent group, only Duk-Woo and Coulomb stenting technique were recommended in this group. So finally, at the 1 year follow-up, the TF rate was 11.4% in the provisional, compared to 6.1% in the two-stent group, largely because the high rate of clinical-driven TR and tidal vessel myocardial infarction of the provisional stenting technique. This is a representative of a case. This is a 49 a young man patient. He presented unstable angina for only 2 months. So angiography showed a very severe disease, right coronary artery. We deployed 2 stent DES. Then we switched to the left main. So from this spider view, you can see it could be defined as a real Medina 111 true coronary bifurcation lesion. The baseline diameter stenosis as the osteosymphysis was more than 70%. Also, the lesion length, I think, longer than 10 millimeters. So it also could be defined as a complex bifurcation lesion. Because this patient was included in our Duk-Woo 5 study in the provisional group. So we gelled wire in single flash and used a long stent to cross over from right to left main. This is the aerial cranial view to show the full coverage of osteoma of left main. Immediately after stenting, we perform pod technique. And immediately after pod technique, circumflex suddenly disappeared. So patient presented very severe chest pain, EKG depression, and also blood pressure reduced to very low level. So we checked a lot of dobutamine and atropine. After that, I tried to rewire circumflex, but I attempted it several times, but finally I failed to rewire. Because the original wire was gelled in circumflex, I used 1.25 balloon along the gelled circumflex wire to restore the blood flow. Immediately after that, I successfully rewired circumflex. And on the right panel, you can see I used a 2.5 balloon to dilate circumflex. After that, I finished the whole procedure using TAP technique. Unfortunately, in hospital, the patient had tidal vessel myocardial infarction, and 9 months of follow-up, patient again presenting a very severe unstable angina. So angiography confirmed the coming of very severe incidental stenosis as the osteoma of circumflex. So we use a DCB cutting balloon and final kissing technique. After 1.5 years, patient did not come to hospital, and TEFON follow-up confirmed a asymptomatic status for this patient. So the last 2 slides, I'd like to discuss something about the provisional stenting technique. As SJ said, almost 25% of bifurcation lesion could be classified by complex bifurcation lesion according to our definition criteria. If side branch diameter a minimal 2.5 millimeter, side branch lesion length 10 millimeter, diameter stenosis 70% for distal left main or 90% for non-left main bifurcation lesion. So two-stent approach, I think it could be the first choice. Of the two-stent technique, personally, I'm very confident that Duk-Woo will be much better than any other kind of two-stent technique. For the remaining of 75% of simple bifurcation lesion, for example, Medina 110, 101, or even Medina 100, I think provisional stenting technique will be the primary treatment. But the question is that, can we predict the requirement of provisional stenting technique with the two-stent technique? Recently, we just combined our 4 database to try to get insight analysis and a comparison between provisional stenting, the provisional with 1 stent and provisional with 2 stent technique. The figure summarizes the 2 choices. So for provisional stenting technique, before the stenting main vessel, we still have 2 different strategies. side branch predilation or not predilation. Finally, at 1 year follow-up, so in side branch pretreatment group, the 1 year TIF was around 16.7% compared to only 11.5% in the non-pretreatment subgroup. I think this will be meaningful for our intervention cardiologists to decide whether or not to predilate side branch. After side branch treatment, so we still have two choices. A two-stent or one-stent technique. So far, another very important issue is the criterion to stent side branch or not stent side branch. Finally, at 1 year, so from our database, there was a non-significant difference in terms of the 1 year TIF between the provisional with two stent and the provisional with one stent group. Thanks for your attention.
Thank you very much, Shaoliang. So now we have about 20 minutes, and I would like to have some discussion about left main PCI and also the technique as well. So maybe I'll start with one question or just a comment, is that, in left main interventions, obviously we always compare to bypass surgery. So as you know, the Excel trial has now up to 5 years. And most of the time, the first year, there's really not a whole lot of difference in terms of TLR. It's really between, after the first year to 4 year, there are more ischemic-driven TLR in the PCI arm. So one question I have is that from some of the prospect trials, the combined trial looking at vulnerable plaque and so forth, should we be more diligent for looking at diseases that are more intermediate at the time of PCI and fix them as well? Because otherwise we're left behind diseases that potentially will make it look worse compared to bypass surgery, meaning bypass surgery is bypassing all the lesion and we only fix the left main, while we kind of left behind other lesions that potentially either FFR positive, or it could be also by image that has plaque percentage greater than 70%. So I just want to have a discussion. Should we be more aggressive and looking at the time of initial PCI, after the left main is revascularized, check FFR, check images to make sure everything is well treated? Otherwise, for 1 year it will look good, but then in 5 years, not so good. So discussion? Any comments? Don't work or...
Yeah, Alan, I think this is very, very good comment. Really, particularly for distal left main, bifurcation as Kwon introduced, they delayed the complication of the provisional standing technique. Exactly 1 year follow-up for left main bifurcation is not long enough. We need to extend as long as possible to confirm the efficacy of provisional. So exactly from Excel, I think most of lesion are distal left main, but not a distal left main bifurcation lesion. I think that's the difference. But also, from Excel trial, at 3 year follow-up, the TR rate was around 7.8%. I think it was pretty high than convention data.
Duk-Woo, SJ, anyone have comments about how aggressive we should? Because I think left main PCI before we were so concentrating making left main, right? Because we were scared that it's not as good as surgery. But actually now you can show that you can be as good as surgery, at least in the short term. Should we be looking at other lesions and making sure that there is no other left behind as well?
I think that's a clinically very important question. That the SAPOC is now running a very important clinical trial, which will prove the benefit of the, kind of a PCI for vulnerable but functionally insignificant. But I would say that for general perspective, the limitation of vulnerable plaque PCI treatment is the low positive predictive value. But if you can narrow the range of the borderline FFR or the very vulnerable lesion, maybe we have a chance to win the game. The other very important thing is that I think post-PCI physiological assessment, because when you do PCI, we we automatically think that we relieve the ischemia. And I think that's one of the main reasons why ischemia was failed to prove the benefit. And when we measure the FFR or the resting pressure index after PCI, I generally become very much disappointed with what I did to the patient, so that the relieving ischemia, prevent ischemia, and also relieving ischemia and define the residual ischemia are the key elements, I think, that to improve the outcome of the PCI and hoping for better outcome than surgery.
I'm just wondering whether we should also take left ventricular function into consideration, because I think we are all aware of the nice publications by SG Park's group, stating that patients who have moderate or severely reduced left ventricular function may have worse outcome.
Okay, so I have a question to Dr. Sunao and Dr. Kenji. Shaoliang Chen introduced the definition criteria to decide the 1 versus 2 stent for treatment of bifurcation lesion. Which factor is critical? You decided to 1 versus 2 stent in your daily PCI practices. Sunao and Kenji, any comment?
But actually, in my daily procedure, I often use many class technique for the true bifurcation, and of course vessel size and some lesion morphology is quite important. But I think the circumflex territory is also important. If the lesion vessel itself is around 2 millimeter, but the territory is quite big, I do not hesitate to select a 2-stent strategy. It's my idea.
Okay. First of all, I think the single stent crossover technique is almost we have answer. Just doing a stenting and then get the good apposition of the stent and checking FFR. If FFR okay, just leave it. So already Dr. Professor Koo and the Korean group show that the science. But the point is double stenting. But even now, yesterday I showed a case. Even now, if we have a proximal circumference area, not so calcified part, we want to do DCA. They want to decrease the number of the overlapping stenting. This is the current idea. Of course, so far, we have a great guy, Shaoliang Chen. He did a great job about the DK crash with the DK crashers. So, but we don't have any another data. But anyway, in the proximal part, we don't have any, not so much calcified part. We not do DCA. But if we have a calcified part on a circumflex proximal, maybe cannot avoid the 2 stenting. But so far, we still using provisional stenting. This is my daily practice.
Okay, SJ, okay, go ahead.
I think it's very classic concept for the bifurcation lesion. Circumflex, according to the circumflex disease status, I have already showed the slide. If free of disease, normal circumflex, whatever size, single stent crossover, walk. It's in always more than 90-95%, right? And even after there's any degree of compromise, in case of a normal circumflex, it's good, even after the long-term follow-up concerns. However, there are some disease status. Recently, I really prefer upfront to 2 stent, upfront to 3 stent. Just Shaoliang Chen is clearly demonstrated based on the data. So the reason why I look at that, circumflex is really big arteries. In many cases, more than 2.530, right? Big one. We can make a big stent areas after the high pressure inflation, IVS-guided, etc., right? That is the reason why. Second one, Alan and Dr. Koo, talking about the vulnerable plaque concerns. So we have some, insight from the prospect observed study and, some preliminary observation of our previous study. Look at this. the degree of stenosis, negative FFR, the degree of stenosis is not too severe. If you deploy the stent, absolutely good long-term outcomes, right? Whatever, situation, bulbar plaque, even in the, not too much plaque for the lesion, the stent outcome must be good even in the long terms, 2 years, 5 years. And so there are some diseases, short lesion lengths or whatever, so we can make a big stent area. There are some vulnerable plaque and angle concerns, technically some, compromised circumflex. If there are some disease, why not? We want to do the two, upfront to two stent. So the circumflex usually matters. However, it is a big one. Even in the, some disease is not too much plaque burden. You should stent result is good. And third one, actually, is clinical follow-up data. Look at it. There are some, recurrence in terms of a circumflex ostium. In almost all cases, actually, clinically not so, big troubles in terms of engine. No medication as a patient is good. So I think as a certain, clinician side, we have to do some procedures. There are some disease or angle, technically some compromised circumflex. Okay, two stent, upfront to two stent, upfront to three stent, it's okay. That's my opinion.
Okay, I have one question to the Shaoliang Chen and the Shaoliang. You are the real pioneer of DK Kershaw, global leader of complex two-stent technique. You introduced definition criteria. So in my concept, it looks like anatomic syntax score is to decide the PCI versus bypass surgery for the main or multivascular diseases. Definition criteria can be used one or two stents. So the question in looking at the definition criteria, the function as well as imaging concept is not implemented in the definition criteria, just the anatomic, criteria. So anatomic syntax score, prognostic discriminative capacity is limited. So I think this is some similar concept. How do you, implement functional and imaging concept to definition criteria would be helpful to decide one versus two stent technique.
Thank you for a great question. I think if we can put the functional variables in the criteria, I think it will be perfect. So this is why I think definition criteria is good, but I think it's not perfect so far. Same thing, I'd like to say the design of definition trial is not only for our Asian operators, it's only for European guys. I think they don't believe two-stent technique works well for very complex peripheral lesion. Also during the process of definition too, a few European centers participate too. So it's very, very challenging for them because they have very limited number with very complex peripheral lesion. But I think it's a real standard for our Asian patient. So that's all. Thank you.
Well, a question maybe for Jung-Min is like, from your standpoint, when you look at a circumflex, that's a bifurcation lesion, and you look at a circumflex by ultrasound and there's no disease, that's pretty straightforward, right? So you do understand crossover. Where would be your cutoff that you start thinking about that you would put a stent in the circumflex origin? Is it stenosis, FFR, plaque burden? What will be your criteria to decide that you would go with two stents? Let's say the circumflex is moderate size, is pretty good territory, not dominant, but some sort of reasonable circumflex that you don't want to be ischemic. What will your cutoff be?
And thank you, Dr. Yeung. I think it's very important questions. Actually, we don't have a right answer yet, but that will be the future, one of our future works for, we have to define it. But so far, the previous Dr. Gang's data shows that after simple crossover stenting, side event jail, functional jail, which means that the FFR less than 0.80 occurred in the 7%. The prediction, there is two criteria to predict the functional jail. One is a plaque burden. The second is a minimal lumen area. The plaque burden roughly 50%. the minimum lumen area, roughly the 4 square millimeters, can predict the functional jailing after simple crossover stenting. So based on 2 factors, it would be important to decide the 1-stent or 2-stent technique. If a circumflex ostium, the plaque burden is more than 50% and the lumen area less than 4 square millimeters, I think upfront 2-stent technique would be better than simple crossover stenting.
Alan, I have one question. Yeah, I fully agree. The answer is responsible by Dr. An. So this is why I said in my slides, so provisional with 2-stent technique should be considered the complication. It's acute complication. One question for SJ. Appreciate your team's work to provide the minimal stent area SM65 for this left main bifurcation lesion after 2-stent technique. But recently, Excel's subgroup study provided different criteria. So, what's your comments?
Okay, sometimes it's important, sometimes not so important, right? The meaning is the Caucasian people's large body surface areas, etc., etc. There are some difference in terms of minimal lumen areas for the main disease, totally different, 6 or 4.5 millimeter scan in our data. So I think as what lesion would be, the high pressure inflation effective stent area should be maximized according to the vessel size. That is more important, right? So if you look at some data in non-main epicardial arteries, actually whatever areas, whatever site, the effective stent area is more than 5.0 millimeter square, it's good. It's good according to the whatever different, drug stent. So there is minimals, some little bit different, cutoff value. Sometimes we have to consider that. However, in the technical point of view, we're gonna have a maximal stent areas, right? That is most important. So minimal requirement is 5, I think. Any vessels, 5, more than 5, maybe not, maybe safe. That is my, all right.
So I'm last question to the Koo, and the Koo introduced the last 10 years, the trend of the bifurcation technique and concept, and the outcome is much improved. What is the future perspective? Which portion is remaining unmet need for treatment bifurcation region, including single stent, 2-stent, any concept, and what is the most important unmet need in field of bifurcation PCI?
So I think that's a very important question for all of us. And the one thing I really like to know is that which patients really need a upstream 2-stent technique. So I think that's not a big question for all of us here, experts in bifurcation. You can start either provisional, either 2-stenting, whatever technique you want to do. But the beginner and learners, it's very important whether they start with the upstream 2-stent or provisional, because if they do not select the right strategy, they will be in trouble, and big trouble for left main. So I think what we need to know, so that we are very happy that the double stenting is as good as 1-stenting when it is done by experts, but it is also reported from Chinese doctors that the less experienced operators, left main PCI is associated with the higher mortality. So that I think that the proper selection, proper target for 2-stenting may be what we need to do in the near future and now.
I do want to emphasize that, imaging is very important. So meaning that sometimes you get fooled a lot, right? So if you want to do left main bifurcation stenting, you got to know how to use imaging to help you, as Jung-Min talked about, plaque percentage, what percentage plaque there is. How can you do that without imaging? How do you know the MLA without imaging? So I think if you can learn imaging and then you can choose 1-stent, 2-stent, will help you a lot. And also to look at the final result. So the only thing I might add is that, I'm just start thinking about whether if I have an FFR open already for some reason, maybe is to double check everything is, FFR negative, meaning I got the right spot. There's no LAD left behind. There's no other things left behind to complete that procedure for the patient. So I think that's just sort of something worth thinking about, is to making sure everything is addressed.
Okay, great. And I think time is up. Is Alan, could you summarize this session and that close up this session, please?
Yes, I sort of just say a few things already, which is kind of the closure, meaning imaging is very important. I think for the right patient, 1 stent will do great. For another right patient, 2 stent with DK crush is the perfect technique. You got to know what you are doing, and I think imaging and physiology is very important in so that you plan the technique correctly, and then you would really end up with a great result either way. It depends on the patient subset. It's not like, applying a 1 stent technique to a really needing a 2 stent technique patient will be fine. It will not be. So I think that's important to be able to predict upfront and learn those technique and make sure that you know how to do both, and then do it well in each particular type of patient that requires that.
Okay, great. So we're gonna finish this session. Thank you very much, all moderator and the panel. It's all discussion. Wonderful.
Thank you so much.
Thank you.
Thank you. Thank you.
Bye.
Thank you.
Bye-bye.
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 Bye. Bye. Bye.
Right.